the Thursday musings. A very important topic, wandering mentally ill, neglected. How are they actually assessed? We are going to discuss a very successfully running model from Kolkata. Uh, the rules of the game are simple. Pawan is recording the meeting. It will be available later on our Facebook page. We are in the process of making the YouTube channel also, so you'll get the link sometime soon. Pawan, next slide, please. Let me hand over the session to Professor Dr. Tufan Pati sir from Cuttack. Sir, I'm skipping your slide. Sir, over to you. Please keep mine and Amrit also. Sir, you have to unmute yourself.
Just a note of appreciation for Dr. Alim Siddiqui and Dr. Amrit Pattajoshi, who had been in this program along with me. We have been there from the very beginning, and they have been very vibrant moderators, and today they will be show. And now I have the pleasure to introduce our chairpersons. Dr. K.S. Shaji from Thrissur is the professor and HOD of Psychiatry at Government Medical College Thrissur, and his area of interest is public mental health and geriatric mental health. He has more than 40 publications in peer-reviewed or indexed journals, contributed chapters in many books, is associate editor of Indian Journal of Psychiatry and Indian Journal of Psychological Medicine. He is in receipt of a number of awards. To just name a few: Dr. Bimla Birmani Award of 2009 from National Academy of Medical Sciences for research work in dementia care. Professor Surinder Mohan Maro Award from the Indian Council of Medical Research (ICMR) in 2011 for the contributions in the field of geriatrics, and received the ICMR International Fellowship for Senior Biomedical Scientist for the year 2011 and 12. The versatile, knowledgeable, learned, smiling chairperson, Dr. K.S. Shaji. Next slide, please. Next slide. Dr. Minna Jafar Nasirabadi, Hyderabad, who is always very much, I find him active in the psychiatric media. He is professor and HOD Psychiatry of Deccan College of Medical Sciences, Hyderabad. He is Vice President of Hyderabad Psychiatric Society and is Honorary General Secretary of Indian Association of Private Psychiatry, Telangana State Branch. With this, I hand over the meeting to Dr. Shaji and Dr. Nasirabadi. Now, the further proceedings is with you. Please take over. Dr. Shaji and Dr. Nasirabadi, please take over. Now the meeting is yours.
I think it's a pleasure to be with all of you today evening. And I think we will directly go to the topic. And I would request the first speaker to start off. We will have discussion. If the chairperson is willing to do that, that is fine. So over to you, Abir.
So shall I start or?
Dr. Minhaj wants to say a few words.
Yeah.
Other chairperson.
I was just going, I'm very small in front of all of you, but I was just going through history of psychiatric rehabilitation. And what I found out was psychiatric rehabilitation is therapeutic approach in management of mentally ill to achieve their fullest potential through learning and environmental support. So either we need to modify these patients or modify the environment. And I could find out 4 types of rehabilitation services: recovery model in persons who have recovered fully, we need to train them to function optimally at society. Then there is a respite model where patients have some residual symptoms. Then there is a rescue model, which is for homeless and wandering mentally ill. I think most of our today's talk will be on rescue model. And then there is a retention model wherein people who have resistant illness and they cannot be treated at home, they are kept. So we have recovery, respite, rescue model, and retention model. So these are the 4 models which I could find out. We have rehabilitation since long in India, during Chola's period, I could find out that there was a Veera Choleshwar Hospital, which was there in temple premises. This was in 11th century. Then I could find references of Firoz Shah Tughlaq. In 14th century, he had hospitals where mentally ill patients were chained and kept. Then I could find out history in 15th century by Muhammad Khilji, who had special hospitals for mentally ill. Then I could find a reference of Maulana Fazlul Hakim. He had a hospital at Dhar Mandu in MP. In 17th century, there was separation of mentally ill people to protect the society, not to treat these mentally ill patients, but to protect the society. And they were kept in hospitals according to, or the asylums according to their social status. Establishment of asylum was first done by East India Company, like proper asylum in 1745 in Mumbai, then in Chennai in 1794, where opium, hot bath and music therapy were given. I could find out reference of occupation therapy started in mental hospitals in 1862. They were divided into working lunatics and non-working lunatics. And working lunatics would be made to work in asylum industries like castor oil, gardening, mat weaving, and other things, wheat grinding. Then I could find out Mysore Lunatic Asylum, where occupational therapy was first started, and their concepts were introduced. OT department was started at All India Institute of Mental Health, which is now NIMHANS. Then there was a European Mental Health Asylum, now CIP Ranchi. Dr. Alim must be knowing about CIP Ranchi. That it was like the first hospital where sports and other occupation therapy activities were done by mentally ill people. This was long back in 1918. Now it is CIP Ranchi. Then there was Madras Government Mental Hospital, where there were wards with comorbid illnesses, like mentally ill with comorbid illnesses. Then special schools in 1964 and 66 were started by Indian Education Commission, and special education NIMH Secunderabad was started. Then in 1960s, yoga for mental health was started. Family support and family participation was started first at Amritsar Mental Hospitals. Community-based rehabilitation centers were introduced in TISS, Tata Institute of Social Sciences. Other institutes which were pioneered were SCARF by Dr. Sharda Menon. We all know Thara Madam is looking after it. There was Darul Muji at Chanchalguda in Hyderabad, where I stay. Now it was shifted to Jalna, and now Institute of Mental Health. There are some NGOs which were working or are working, like ASHA, Dr. Bharat Watwani sir's Shraddha Rehabilitation Center, for which he has also won Magsaysay Award. Then there is this Banyan Halfway Home for mentally ill homeless in Chennai. And now with MHA, MHCA, PWD, we have various acts. I think Dr. Abir and Sarbani Madam will talk about their centers and how things are now.
Hello, may I request the chairpersons to please introduce the speakers, and
Okay.
and Pawan, would you please share the slides of Dr. Abir Mukherjee and Dr. Sarbani Dasra?
Dr. Abir Mukherjee is Senior Consultant Psychiatrist, Medica Super Speciality Hospital, Visiting Consultant Psychiatrist, AMRI Group of Hospitals. He is involved actively in training and field of clinical work with an NGO organization, Ishwar Sankalpa, caring for homeless mentally ill. His areas of interest were developmental disorders in children and adults, rehabilitation psychiatry, neuropsychiatry. His major achievements are Treasurer IPS East Zone, Chairperson Child Psychiatry Subspecialty Section IPS, Executive Committee Member IPS West Bengal State, ex-convener IPS Postgraduate Education Committee, ex-convener IPS Ethics Committee, around 40 publications, audits in international and national journal, ex-examiner in preparatory MRCP courses in UK, regular panelist in TISA, regular speaker in various CMEs at state, zone and national levels, membership various members, member of Royal College of Psychiatrists, Life Fellow of Indian Psychiatric Society and West Bengal Medical Council. Next slide, please, Pawan. Miss Sarbani Das Roy, Kolkata. She's from Calcutta. She's Social Developmental Crusader and Ashoka Fellow, pioneered an alternative pathway of care for homeless mentally ill, co-founder and secretary Ishwar Sankalpa, psychological counselor, MBA from IIS WBM, graduate with honors in English from Calcutta University. She's a Ashoka Fellow, a developmental professional with over 2 decades of cross-disciplinary experience in NGO, administration, project management, research, consultancy, training, resource mobilization, community mobilization, and project execution at field level. Thank you. Now I would like to ask Dr. Abir to start his presentation. Dr. Abir, over to you.
Thank you. Thank you very much. So let me first share my screen and then I'll make a start. Are the slides visible? And am I audible?
Yes, sir.
Thank you. Good evening, everyone. And it's a pleasure again to come back to Thursday Musings. Well, I have been a regular listener, and in terms of active participation, I may be mistaken, but I think I came for the 52nd meeting where most eminent Professor Shekhar Sheshadri gave a very, very riveting kind of lecture. And I was fortunate enough to be one of the chairpersons for the meeting. So yeah, it's like homecoming, and thank you very much, Dr. Tufanpati, Alim, and Amrit for inviting me once again. And I think this is an opportunity for us to highlight about the project, which is Ishwar Sankalpa, and later on we can answer questions. So basically, the design would be that I would be speaking for around 20 to 25 minutes, and likewise with Sharbani Di. And following that, we'll have a discussion with regards to whatever has been discussed or the work we are undertaking. So without further ado, I'll just start with Ishwar Sankalpa model. I'll start with the prelude. So basically, what I would include is I would include some cases and just a snapshot about about the successes and the difficulties of the cases. And then I'll highlight the importance of rehabilitation programs in the context of a huge and vast country like India. So I would first describe this man. So words fail to describe how awful Mr. B looked when we first found him sitting on top of the statue near Kakurgachi, somewhere around March last year. He was thin as a stick, so much so that one could easily count the ribs in his body. It was initially exceedingly difficult to make any communication with him. He couldn't even answer whether he was hungry. He simply used to come along and take his food, speaking little to nothing. So he was diagnosed with schizophrenia, and with the Noyador wing of our project, most of the diagnosis, as you would expect, is schizophrenia. So the major challenge in the initial days was his wandering tendency. Again, one of the issues about today's discussion is about the wandering tendency. After starting medication, it was easier to establish rapport and engage him. Soon his words started making sense as he could express his needs, be it in food or any other requirement. After medication, regular engagement, and therapy, one day, to our surprise, he came to us with his hair trimmed and beard shaved. After a long period of patient inquiry for days and fitting all the bits and pieces of information together, it was finally discovered that he had a home nearby where his mother lives. The next step, and a very important step, was to psychoeducate his mother. We also told her that we need to provide him with the medications, talk to him regularly, and make sure he's being cared for. He was on the verge of losing his regular habits of leading an everyday life, And it was our job to bring his life back on track, with, of course, the assistance of his mother, who was still the principal and primary carer. The metamorphosis. Since the last couple of months, he started spending nights in his home. His condition improved significantly, so much so that he has a job now. He searched and got the job of a rickshaw puller on his own and makes a decent enough living. So this is one of the success stories of our Nayadaur wing of our project. But I mean, all are not as rosy. So there are fraught with challenges. We do face a lot of challenges, but at the end of the day, we face all these challenges. And when we see success, it's a real, that kind of pleasure, it's only can be felt, and it's very difficult to describe. So now coming to the main bit of my presentation, mental illness, a reality check. As per the National Mental Health Survey guidelines in 2015 and 16, prevalence of schizophrenia in the Indian population is 0.5% for current and 1.4% for a lifetime experience, and the incidence is about 1.5 per 10,000 people. And the treatment gap for severe mental disorders is 73.6%, of which psychosis is 75.5%. So more or less, it's equivalent to the severe mental disorders all have a similar kind of treatment gap in the range of late 70s and early 80s. Number of psychiatrists per 100,000 population has now increased to 0.9, which means 9,000 psychiatrists in the whole country. And you can see the burden of schizophrenia on its own. The Mental Health Atlas of 2017 reported a median number of less than 2 mental health workers per 100,000 population in low-income countries like India. Again, the Mental Health Atlas of 2014 reported that the number of clinical psychologists was 0.07 per 100,000, which is around, I think, close to 700. And the number of psychiatric nurses was 0.12 per 100,000. The number of public funded long stay facilities in India is nil, unless the data has changed. The rural area that accounts for nearly 70 to 80% of the population would have at the most one psychiatrist per million population. 36% of the population still live below the poverty line and unable to access mental health treatment. In this generation of nuclear families, the burden on the family to take care of the mentally ill has increased. So, we were kind of, till the international pilot study of schizophrenia, we always felt that the family support is our main, strength in terms of management of schizophrenia and other severe mental disorders. But that is gradually dwindling away with, the cultural shift. Added to this is the social stigma about disclosing mental illness unless the person is absolutely unmanageable. So we have dwindling resources, and on top of that, we have this extreme stigma, which still, persists. "75% of people with mental illness are treated by traditional healers. In this process, the psychiatric treatment, in terms of the psychiatric, the formal psychiatric treatment is often delayed or does not happen at all. The illness becomes chronic and the person gradually drifts away from the hostile and critical environment of home to become homeless in the big community. So this is how the path to chronicity, and this is how the path to homelessness begins or ends. So there, our work starts. When the person becomes homeless, so we deal with that 20% of individuals who have a chronic mental illness and who have been rendered homeless because of lack of support, stigma, and all the other nuances which are involved in the process. The number of people who are homeless in India is around 1.77 million based on the 2011 census. Again, the National Mental Health Survey estimates the number of homeless persons with mental illness across various states to be almost minimal to 1, but in some individual states to be as high as 15,000. As you might well understand, that there cannot be so much of a difference between state to state, and the data cannot be so skewed. So obviously there is a difficulty in data quantification and the lack of awareness of the key informants. Now, what are the problems faced by the homeless mentally ill person? Of every 10 homeless persons, 4 are said to be suffering from mental illness. They also suffer from serious health complications. Homeless women with mental illness are extremely vulnerable and are subjected to sexual harassment. We have seen this in our project, and that is how our project has evolved, that Sharbanidhi would detail later on. 90% of men rescued have some kind of physical injury. 20% of people suffer from major physical ailments and also are at high risk of HIV infection. Due to lack of available shelter, these people often wander away and get lost. In a month, at least one patient rescued needs admission for a comorbid condition, and that is as far as our data goes. Homelessness is a complex problem related to a wide variety of factors. There is no organized system of mental health care to respond to the needs of the homeless mentally ill persons. Families form an important and dependable support system, as I alluded to earlier, for people with mental illness in India and all over the world, for that matter. Disabled persons falling out of the safety net of the family is a clear indication of the failure of the system to provide adequate support to such families. And there comes the need of legislative protection. Mental disorders sometimes affect people's decision-making capacities, and they may not always seek or accept treatment for their problems. And this is unique about mental disorders. Coupled with this, they may pose a risk to themselves and others. Legislation must strike a fine balance between the individual's right to liberty and dignity and society's need for protection. Now, coming straight away to our Mental Health Care Act 2017 and its implications in terms of the homeless persons with mental illness, I hope to discuss this further in our discussion because this is a very important area, a burning kind of a topic. So the Mental Health Care 2017 is a right-based legislation, as we all know, with a lot of obligations cast upon the state with regard to the homeless persons with mental illness. For example, Section 100, it's not only Section 107, but all the other subsections of Section 100 as well. So what are the duties of public agencies while delivering care to the homeless persons with mental illness? For a person with mental illness and found wandering in the community, an FIR of a missing person should be lodged at the concerned police station, and the station house officer shall have the duty to trace the family and inform the family about the whereabouts of the person. So this is what is expected out of the Mental Health Care Act. If, however, the family is not found, the MHCA designates the OC of the police station to take the wandering homeless person with mental illness in his or her jurisdiction and later take him to the nearest public health establishment. I mean, these are all kind of has been defined, and subsequently on the basis of assessment be either admitted to the mental health establishment or to a government establishment for homeless persons if admission is not necessary. So I describe this in detail because this will be important later on. They also have the right to free legal aid under Section 27, subsection 2. Also, the homeless persons with mental illness are entitled to mental health treatment and services free of charge and at no financial cost at all mental health establishments run or funded by the appropriate government and other mental health establishments designated to it. The Mental Health Care Act 2017 has thus brought in a list of rights for homeless persons with mental illness and has taken away the involvement of the judiciary to provide care, unlike the 1987 Act, where all the steps had to be affirmed by the magistrate, and thereby preventing undue complications and delays. Mention about clear frameworks of the need to protect the rights of persons with mental disorders, especially in case of supported admissions, both short and long term in mental health establishments. And it has got a definition of mental health establishments. So basically, I'll just read the underlined parts. established, owned, controlled, maintained by the appropriate government, local authority, trust, whether private or public, corporation, cooperative society, organization, or any other entity or person, admitted and reside at or kept in for care, treatment, convalescence, and rehabilitation, either temporarily or otherwise. So anything under the sky dealing with mental health. The confusions in the existing legislation. There is little understanding of the need to protect the rights of persons with mental disorders when treatment is administered without their consent, to prevent relapse, and without any right to review when in the community. There is nothing similar to something like a community treatment order as in the West, which would have helped to protect the rights of these persons undergoing treatment and rehabilitation, either without consent or even compliant persons lacking capacity. So this is also a very important area in terms of the Boneville trial, which happened in UK. It's not easy in this city. So I'll describe about, whereby the conflict comes. Around September, a man was found living on the streets of Joragija Park Circus in Kolkata. Following the usual protocol of assessment, he was diagnosed with schizophrenia with predominance of negative and depressive symptoms. The team regularly started offering him food and catered to his other requirements. The medicines provided to him seemed to work just fine. Slowly and gradually, he started engaging with the team and showed signs of improvement. So this is the good part of it. But now comes the problems. He gradually started complaining of loose motion. Initially, we thought it was gastroenteritis, which happens often in these individuals living in the community because of their lifestyle. By the 15th of November, he seemed very ill. So this is a very recent happening. He confirmed that he could not walk. The very next day, he was admitted to the Hope Hospital, which is, part of the, you have to pay for the facilities in this hospital due to significant deterioration of his health. So when he was admitted to the Hope Hospital, we had to pay for the facilities, unlike what is mentioned in the Mental Health Care Act. The next day, he was tested positive for HIV. As the costs were prohibitive, the team started exploring various shelter homes that work with HIV patients. Admission or domicile was refused on various grounds. The team even tried to contact the local police, as it was impossible to leave him on the streets. The police refused to take any responsibility for the homeless individual, in contradiction to Section 100 of the Mental Health Care Act. After getting the reports from Tropical, the team lodged a GD. Well, if you talk about an FIR to be lodged, the police won't even entertain. With all the documents and the GD report, the shelter, which initially agreed to take the patient with reports, now refused without giving any specific reason. So we have to be at the whims and fancies of these various homes where they cater for various kinds of problems like this. On 24th November, he was registered for ART treatment from SSKM, which is one of our tertiary hospitals in Kolkata. That day, with the help of a team member's good contact. So again, we have to depend on all this rather than a legal platform. They could admit him to a home at last. His ART will begin from 8th December in SSKM. So, the dichotomies. Was the duties of public agencies while delivering a care to HPMI Section 107 met? No. Was the right to free legal aid met? No. HPMRs are supposed to be entitled to mental health treatment and services free of charge. Was that criteria satisfied? No. Taken away the involvement of the judiciary to provide care? Well, we really don't know. That has not been, but I'm sure that it wouldn't be possible again till now. The care home be under the purview of a mental health establishment? No. So this is the reality. So this is how schizophrenia is. I wouldn't get into details. So this is what happens in the premorbid phase, then the acute phase, and then with the remission phase, subchronic phase, and chronic phase. So this is how, schizophrenia progresses. And as we reduce the duration of untreated psychosis, the more we reduce the duration of untreated psychosis, the better would be the response. And we can also see that the cognitive symptoms and the negative symptoms appear very early in the course of the illness. These are the positive symptoms. which can be taken care in the initial stages, but we have seen very resistant hallucinations and delusions in our, in our project as well. The negative domains are the ones which reduces the functionality, alogia and blunted effect, abolition, apathy, lack of energy, anhedonia, and social withdrawal, and the cognitive impairment. This is, I think, significant, and this is what causes challenges in social rehabilitation. And unfortunately, for the negative and cognitive symptoms, we all know that the role of medications is still, we are still searching for the right pill. The language, motor functions, and the visual spatial functions are relatively less affected. So that brings us to the required provisions for long-term care apart from medications. So most psychiatric patients requiring long-term care have schizophrenia, chronic affective disorders, dementia, personality disorders with persistent aggressive behavior or substance misuse. In the community, certain provisions are required to replace long-term care in hospital, and that has been our aim. Lack of these arrangements may leave patients homeless, without constructive occupation, inadequately treated, and without a carer. Lack of community care may also leave carers unsupported and family life disrupted. So what are the components of community long-term care? Suitable and well-supported carers, appropriate accommodation, which comes later in our practice, suitable occupation, arrangement to ensure patients' collaboration with treatment, regular reassessment, including assessment of physical health. That is also a big challenge for us. A model like an assertive community treatment, now widely used to maintain patients with chronic schizophrenia in the community in the Western countries. Well, if we have enough resources, we can think about it. The help may be provided in an inpatient unit, day hospital, or rehabilitation center. Medication to control symptoms, psychological therapies. We have psychologists in our team with supportive therapy, behavior programs, social skills training, occupational therapies, activities like gardening, crafts, cooking, adult literacy, and other activities that can provide a sense of achievement. Social, encouraging to join social groups and special clubs. This helps to alleviate symptoms of social and emotional withdrawal and lack of volition, as in the negative symptoms. So this has been our flagship, Abdullah. There was, Sharbani went to attend the Kaun Banega Crorepati program. We invited, Ishwar Sankalpa was invited, and there also we had Abdullah. He also went along with him, along with her, sorry. And this photograph is taken in Nihal's shop where Abdullah worked for 12 years on the day Abdullah met his family for the first time again. His daughter worked in the same hospital where he worked as a radiographer 30 years ago in Sangali. A senior staff member at the hospital recognized his image that was shared in a WhatsApp group to identify the missing person. So thank you. That ends my bit of the talk. And before handing it over to Ms. Sharbani Dasroy, I just wanted to mention about Dr. Minhaj mentioning about, this being more of a rescue project. I would just say that our project also involves recovery, rescue, retention, and all the bits of it. And this would be highlighted by Ms. Sharbani Dasroy. Thank you very much. Thank you for your time.
Good
evening.
Thank you, sir.
Sharing.
Shall I share my screen now?
Oh,
Sure,
I'll
ma'am.
stop sharing. Have I stopped sharing? Yes, yes.
Is it visible?
Yes.
So I will take on from where Abhi left, and I will I'll actually be telling you the story of Ishwar Sankalpa, not so much of facts and figures so much. A little bit I will touch, but I will tell you of why we started and how we have come this far.
Sharbani, you have gone on mute mode. Please unmute.
Okay. Yeah, can you hear me?
Yes.
Yes. You can start again.
Yeah. So I will take off from where Abhi left, and I will go straight into the journey of Ishwar Sankalpa over the last 14 years. I'll be talking to you more like a story. So, and at the end of it, you can, have your questions ready. So the reason why we started, when we first saw a homeless person on the street with mental health conditions, it's not that this was the first time we had seen him. We have grown up in Kolkata, and there have been many times we have seen such persons, but usually they have been invisible because we tend to look away from such persons. They represent a problem which we were not yet ready to face. We did not know the length and the breadth of the problem, so we look away. We try to find easy solutions and we go into those rather than look at this huge complex problem. Why am I saying it's a complex problem? Because this is not just a mental health issue. This is a human rights issue. All his human rights, everything has been violated, including his right to life. This is a person who is also vulnerable to STD, HIV, AIDS, as Abid just mentioned, and a host of other infections and physical health issues. There could be dog bites, there could be injuries on the head, there could be maggots where the injuries have actually taken place. In fact, homeless persons with mental illness have a lot of head injuries also. He's a law and order issue. The police would actually be looking at him as a lawbreaker. This is where we started. He represents a chain of broken families. So if he's homeless and he's abandoned on the street, he's obviously had, already there are certain people who are probably could be waiting for him. He is also a person who is inviting violence in all forms. So there would be children who would be throwing stones at him. There would be, hot water thrown at him so that he moves away from that place. So there is all sorts. This is not just a mental health condition. He represents all sorts of issues, and it's a very complex issue. So when we started this work, we had tried to understand this problem. So where do we go? Do we go to the social welfare department or do we go to the health department? So when we went to the social welfare department, the social welfare minister at that time had told us, ma'am, because he's homeless, he's our subject. But because he has a mental health problem, you have to go to the health department. This was in 2007. So then we went to the health department, and the health department, the minister had said that, see, because he is a person with mental illness, he is our subject, but because he is homeless, we cannot do anything about him, because at that point of time, the institution of the family was very important to get admission for this person in any hospital. Hospitals only recognize people with a family and an address. If the person was homeless, he could not be admitted unless there is someone who is guaranteeing all his costs. At that point of time, our NGO had no money to actually cover costs, so we could not do anything. So we realized that he was actually in a place where he belonged nowhere. He was neither the social welfare department subject fully, nor the health department subjects. When we took him to a hospital, because he needed an appendix operation. If we took him to the hospital, they would say you have to treat his mental health problem first, otherwise he cannot get admission over here. And then when we went to treat him for mental health, if you put him in a hospital, they would say you have to treat his physical health condition, otherwise he cannot be given psychotropic medication. So basically, like in India, there was one point of time when I thought that you can either have a mind or you can have a body. You can't have both if you are poor. So that is from where we started this work, this journey. So this was in 2007, and we decided that since we had no money, we had to think of a way in which we could involve the community to take care of these people, because we could not rescue a person and put him in a shelter or a space which needed money. That is how our community program started in 2007, where we identified 3 types of persons who were homeless with mental illness. One was a population who were more or less, sticking to one territory. So they would have a place under a tree in a certain neighborhood, they would stick to that neighborhood. They would be wandering, but they wouldn't be all over the city. Then there was one category of people who were extremely mobile. So from one place to another, and they could be a threat to others. So these are the people who needed hospitalization. There was another segment of population who was vulnerable due to homelessness. So first we decided that we will look into the persons who are more or less stationary. And we started a community program from 2007. We first did a survey. We had found a point-to-point survey. We had found 466 people who had psychosis at that point of time, mainly schizophrenia. So we started our program from then. And the way we did it was, because this person was isolated from his family, he had no one, we tagged him with a caregiver who lived in that community. So even if he had no one, he probably used to drink tea. Everyone in India drinks tea. Yeah. And there is always some chit chat going on if you look into the streets. And that is how we tagged in the tea giver, or, a small shop owner in the street with this person who would become the caregiver. You will be happy to know that this program has in this year been recognized by WHO as one of the best outreach programs in the world, for community mental health, because it looks into the choices and preferences of persons with mental illness. We did not pick up the person and put him into an institution. We tried to keep him in the same environment where he felt comfortable, even if it was not his home. And we built our program around him. The doctor went to him. He did not have to come to the doctor. So that was how the whole program was arranged. And this was from 2007. In 2008, we worked further on this program, and we built up avenues for vocational skills, employment. What happened was that when we started giving medication to this person on the street, it was a caregiver who would be giving the medication, and our social worker and our doctors would be visiting and keeping the supportive environment for the person, explaining it, everything to the community. And what happened after that was that when this person slowly started becoming better, the community could see that a person with severe mental illness who did not have clothes on his body was now, after say 15 days or 1 month or 1.5 months, now wearing clothes and having eye contact. He was looking much cleaner because he was getting his hygiene regularly checked and helped with. So the fact that mental illness is not such a burden, and it is not, people have a lot of stigma around mental illness, that was being addressed right there in the community. It wasn't, the change was not happening behind the walls of an asylum. It was happening there on the street. And it was one of the ways in which mental health stigma was being, lots of myths around mental health were being broken. This was how we started. And when this person became better, it was a community caregiver who took he felt he was the one who was responsible for this recovery, and we gave him that acknowledgement also. So this was how the program, Naya Daur program, has been going on from 2007. What happened in 2009, what we saw is that there was one woman who started getting better, and then what happened is, because she was more cleaner, she was gang raped and she died. And then, we had taken a vow that this should not happen again. So that day when I had gone to the police station, to say that, please, can you help to find out who the culprit was? I remember this police officer, he had told me, don't you have anything better to do, ma'am? You seem to be coming from a good family. Why don't you go and look after your family instead of, running after a mad person on the street? And, I have more important things to do. My minister will be coming and I have to see that the streets are clean. And I said that, okay, I'm going now, but I will come back again. And then I had found one line in the 1987 Mental Health Care Act, which said, one line in section 25, I think, which said, the police are the guardians of the homeless persons with mental illness. So with that one line, I went to the police commissioner in Kolkata. And I told him that I needed his help because the police were extremely insensitive to homeless people with mental illness. And he said, like, he was like, he initially started saying that, look, why are you coming to me? I mean, you should go to a doctor, you should go to the hospitals. So I said, sir, this is what is written in the Mental Health Care Act. You are the guardian and like, you have to help me. I think that was the first day he read that mental health care, that one line in the Mental Health Care Act. And thereafter, he was a changed man. He said that, what do you want me to do? And I said, you have to give me a space in a police station where I can put up a daycare center so that these people, they don't want a shelter, they don't want to stay at night, but they want some place to rest. And also I wanted the police to know and to realize that they are people who need help, not the stick. So that is how we started the daycare center in the Hastings police station. And it changed our relationship with police to a large extent. After that, the Kolkata Municipal Corporation, I was again at the doors of the Kolkata Municipal Corporation to give us a shelter for women, a place where they can sleep at night without fear of being raped and abused. And we got that shelter in 2010, and nearly 500 people have stayed in that shelter, and it's an open shelter. So people can come and they go out when they are when they go out for work. They've started going out work and all of that. It's quite an open shelter. After that, in 2012, we realized that when we look at the whole mental health scenario and the homeless people, every day, if we stand in one of the major railway stations, we will see that there would be at least 5 to 7 people coming in the trains, from the rural parts of Bengal or from other parts of India. And we decided, like, if we can't stop people from coming into Kolkata, at least we can stop people from going out of Kolkata. If we can do it, if we can help people with early intervention. That's how we started our urban health program, mental health program, where we collaborated with Kolkata Municipal Corporation, and we started holding clinics in all the wards of Kolkata. Like, we have 8 wards where we are holding, where the slum population is large. We are holding our mental health clinics over there. Kolkata Corporation is giving the medication and the space. We are giving the professional help. And that is how, we are trying to see whether how much we can actually integrate this with the primary healthcare system also. So we are working on a MOU with Kolkata Municipal Corporation, and they have really taken this quite seriously. So in 2015, then we realized that there were men who were also vulnerable on the streets, and this whole gender bias regarding the vulnerability belongs to the domain of the woman was a myth also. And there were men who were extremely vulnerable. And the worst thing about suffering men on the streets, is that even we found that even when they become better and when they reach out to their families, unless they are earning, families are not welcoming of men. But with women, they are more welcoming, like, acha, theek hai, woman, it's okay, like, send her home. But with men, unless they are earning, okay, if you're not earning, you stay in the city and you start earning. That is the kind of response. And unless the parents are there, the men are not welcome back home, especially when they reach a little old age. So that is one of the learnings. And we started a shelter for men in homeless men with mental health problems in 2015. In 2016, we started a community program. We realized that there would be at least 40% of women in our shelter who would never be able to go back home. And some of them are quite young in life, but their husbands have married again, their addresses have changed. And as Dr. Abid said in the earlier presentation, because of the cognitive decline, many of them can't remember their addresses. So they will never be able to go back home, yet their lives are still, there's a lot of their lives ahead. What are they going to do with their lives? And the one thing that we've realized is that it's not about just giving medication and having a mental health program which makes them stitch bags and, paint cards. It's about having a purpose in life, having, being able to reorganize their life again to make it meaningful and, be a part of a community. That is more important. And that's how we started Nayagram, where we've started with 12 now. Till now, nearly 25 women have stayed at various points of time. There's a lot of agricultural work that they do. And I think going back to their roots is something which many of them really enjoyed. And this is probably the closest they'll ever be able to go back to their home. So that's one of the things which we have learned, and it's very successfully being run. In 2017, the urban mental health program also expanded, and now we are covering 8 wards, which is about 7 boroughs of Calcutta. In 2018, we started a crust and core, a cafe, a mainstream cafe in Kolkata, which where, like, the training of women in bakery and confectionery, that was taken to a kind of perfection. And we thought that we will, have a space where people can come in and meet people with mental health problems, just to see that, and have a conversation with them also. So that, it breaks certain myths that, they come from like some other planet. It's not that. Many of them are extremely vocal and they can have a very nice conversation also. In 2019, we started a homeless women's collective from many homeless women in Kolkata who are not necessarily mentally ill. So this has been more or less our journey. And then the pandemic happened in 2020 and everything was like, strewn apart. But then we are also again collecting things back together. So one small slide I will say about the journey of recovery that, we have seen, especially for homeless persons with mental illness. One of the things that happened with them is, in order to, our whole aim is, social and clinical recovery. We harp more as much on social recovery as on clinical recovery. So the hopelessness that happens, when they are, we initially find them is, one is the pain of the symptoms, all the hallucinations, delusions, all of that, the absence of family, friends. Many of them have just started on this journey with a child on their laps, but on the way they have lost the child and they can't remember where that child is. And, especially when their memory starts coming back and they recall their family and they are not being able to reach them, that whole pain, it's extremely it's very acute. And the absence of resources to sustain life. These are the points which sort of, make the kind of hopelessness. And then the intervention which actually tries to re-establish the affiliative processes, the treatment processes, which leads to the social recovery. So the blocks of affiliation which we have found is the outer blocks are the stigma, the fear and anxiety of people around them, because they don't want to reach out to a person with who's homeless with mental illness. There is a double stigma attached to this. The burden of care, the mistrust, and the indifference to such problems. The inner blocks, what happens within the person, is the shame, the language barrier, because a person who is coming from Chennai would find it very difficult to converse with someone in Bengali over here, because they would not understand, neither would they be able to express, and they became lost forever. So that is one of the blocks that homeless people with mental illness do have. The physical pain, the hunger, the rough living. Many of them die just by dehydration. The intrusive memories, the threatening emotions, the anxiety, and the distressful voices. All of these are the inner blocks. So the process is, first, as I said, we build a rapport with the person. That is the most important part of the entire process. And that may take 2 months also. Okay, so the social worker identifies the person and builds rapport. This is the most important part. Then we respond to the immediate needs of the person. It could be a shirt, it could be just water, anything. We also do a community resource mapping around that time. So what are the resources that we can get for this person around that, around where this person is staying? We tag him with a caregiver. Then we negotiate treatment. If the person is willing to go to a shelter, we transfer him to a shelter. If the person is not, then the psychiatrist comes and does the assessment. Follow-up is done by the social worker, the counselor, and then a proxy family link is established with the caregiver around him. Thus, this is the community care program where the task sharing is done with the community caregiver. If the person decides to go into the shelter, any of the shelters, Then the shelter rehabilitation, reintegration opportunities. What happens in the shelter is more of a habilitation rather than rehabilitation, because the person is taught new skills. Then there is the assisted community living, which I told you about, where rehabilitation, agriculture, animal husbandry activities are taking place in the rural parts. So what happens with the community caregiver? Why I'm highlighting is because this is the central part of the entire community care model. And what happens is that what the person gives, the community caregiver gives to this person. These are two total strangers actually building bonds on the streets. By way of conversation, he increases the social acceptance, increases the self-esteem of the person. He sometimes gives foods and clothes. When the caregiver is himself coming from a family which is struggling, he could be just a chaiwala, but when he is bringing food from home, when his mother puts in 6 rotis, he also puts in additional 4 rotis for this person. So he is actually contributing to this entire care process. When the person starts getting better, he's also giving medicine. So he's helping the person to regain health. When the person starts getting better, he's offered employment in the tea shop. So by that, he's breaking the lifelong stigma that this person is a lifelong burden. And there is a mutuality in a give and take. It's not that the person is only receiving from us. He's giving back to society. And that is what recovery is all about. Numbers that matter: till date, 3,440 homeless persons with psychosocial disability have been provided treatment and services through the community-based care model. 604 women have been provided safe shelter. 129 men have provided a safe shelter. 468 persons have been restored to their homes across India. So many states of India. 775 persons have been in employment. 16 persons have been provided training in vocational activities. In the urban mental health care unit, we have registered 4,633 persons who have, we can say that, these people, at least early intervention has happened with them. There have been awareness programs where 51,000 people have been, participated. 476 CBOs have been included in the network to provide various kinds of supports to persons with psychosocial disability. Isha Sankalpa is not the only organization which has done this huge work. It's been like many organizations. In many ways, they have contributed to this. And the best part is that that homeless person who did not have any identity, who had lost everything, now has 120 persons have received ration cards, disability cards, Aadhaar cards, and even their own bank account. So we have been able to facilitate this process where they have reclaimed their identity and they are nowhere persons no more. So we have various future plans, and we wish to continue, and with the Nayador program, we wish to focus on tagging these persons with the urban mental health clinics so that both programs can become integrated in the municipal wards. Shelters, we need to extend our services to a further population. Nayagram also, in the rehabilitation program, in the community assisted program, we will be training them extensively on various other poultry and other activities, which they are already acquainted with. In the crust and core, where they are doing their rehabilitation in their habilitation work in their bakery, there we are also like building the momentum to make breads and cater to the mainstream markets. With a women's collective, we are building a cohort of peer leaders who can train subsequent batches of members, and they have already registered as a CBO. The organization is also facilitating rehabilitation work in the vagrants' homes, in the beggars' homes, which we call in other states, in Uttarpara, which has about 600 residents. So the government has invited us to, so that we can share our model of work with the staff over there, which we have already started. We are doing quality assurance framework within our program so that we can be assured of our quality, the quality of your work, and we are constantly trying to improve our quality, and we have set indicators which are also looking at those. And we are also developing our MIS, which we are quantifying all our successes. So thank you. That is all for now. Now we will invite questions.
Thank you so much, ma'am. It was a riveting presentation. Over to the chairpersons for their opening remarks.
Thank you, Dr. Abir and Sharbani madam, for your wonderful presentation. Like Ishwar Sankalp, we have various organizations all over the country. I think many of as a number of psychiatrists in our country are improving. We have in our state of Telangana, small state of Telangana, almost all districts have a psychiatrist, and we are having various programs for mentally ill people. Various district hospitals and government hospitals are having psychiatrists over there. So I think with coming time, we'll see lesser number of wandering mentally ill patients. But till that time, we require services like Ishwar Sankalpa. And with country like ours in India, I know of a mentally ill person working for a dudwala, a milkman. I used to get milk from a person, and he had one fellow of a different community, different caste, different community, and he had employed him, and he was mentally ill, and he used to say, "Daksab, you are coming to take milk. Can you prescribe some medicines?" He doesn't sleep well, and sometimes he talks to himself, but he was working. So in country like ours, we have lots of people who help these wandering mentally ill people, or people staying on street, and there are people to feed them. So this is a good part of it. In Western countries, when I was going through literatures, they had started a program wherein an educated person would take care of a mentally ill person, and that program was unsuccessful. In 1950s, I think that program was started by some Western country. I don't remember exactly when I was going through literature, and this kind of the program you are doing, this kind of program was started by them, and it was a failure there, because nobody would like to keep a mentally ill person, bring him to his home and teach him things. So the program was a failure. But in country like ours, this program is quite successful. Like community-based mental health treatment is a successful thing. So as Dr. Alim said, we should all psychiatrists and also psychiatric social workers, occupational therapists, and mental health workers should try to look into things, go to the society and take care of such people. Thank you. Over to you, Dr. Shaji, sir.
I think it's really great, very impressive work. I think this has to be scaled up further, and other parts of the state and probably the country need to learn from the experience of Abir Mukherjee and Sharbani. And I think this is something which is needed. I'm sure all of us would have seen wandering mentally ill from our childhood days in our village or town. You will always see them if you look for them. As Sharbani had rightly said, we tend to look away from them, and I think that is a huge problem. That's a society's problem, and I think it's very interesting. I think it is important to connect people. I think please correct me if I am wrong. You had succeeded because you could manage to connect people in the community to those schizophrenics who are in need of some connectivity, social connectivity. And I am delighted to note that these community health workers are indeed very pro-social and very, what shall I say, derives a certain experience of happiness and self-fulfillment by doing this. And there are so many people like that in the community out there. If you could facilitate this connectivity, it will be great. I'm reminded of this connecting people intervention, which I believe Martin Weber in the UK had tried in the field of rehabilitation with certain trusts. I think that's something which we are trying to. I'm now currently working with the university, Kerala University of Health Sciences, after my retirement as the Dean Research. So we have a section, school for Center for Disability Studies. So I am trying to convince them to talk to administrators so that we can identify people in the community who are willing to help, and then connect these people who need sustained help. What you are doing is providing seamless support and help for those who are in very bad need of this. I'm extremely happy that good work is being done, and I think this is something which all of us can try and do. And of course, if you focus on this, I'm sure you will need to put in many years of continuous work. Thank you very much for sharing your experience. That was a great listening opportunity for me personally. Thank you so much.
Thank you so much, sir. Maybe now take some questions from the chat box and those people who have sent to us. Yeah. So let me start by saying, congratulating you. It all started when we met Dr. Abir in a conference recently. So kindly tell me, if I want to, suppose I want to start a center here at Lucknow, what team building should I have? What should be my team components?
What Sharbati, would you answer, or?
Yeah.
Yeah.
So you need social workers, you need a counselor and a doctor, and what you will need to, the main thing is that the social workers will have to move around and not be looking at persons just because of their symptoms, but try to understand like what is happening to that person in isolation. So that is very important. Not look at only and look for the symptoms only and try to treat the symptoms, but what is happening to that person in isolation. As I have said, what are the inner blocks which are happening, and what are the outer blocks that are happening in the community. And if those can be addressed slowly, because the outer blocks are the ones that community members are actually, there's a lot of mistrust, there is fear, there is anxiety in people around this person, so if those can be addressed and this can be addressed, so probably for the social workers, a little bit of training of, understanding the pain of a person who is homeless with mental illness needs to be given. A social worker needs to be able to walk along. So it's not always, the person will not be going around in a car all the time and an ambulance all the time. He has to be just another person on the street who is able to talk. So one of the first things that, whenever we used to recruit people for this program, we used to first tell them that, can you walk? Like, do you have good walking shoes? And, if you can walk and if you can bear the heat, only then you join this program. Otherwise, it's hard work. It's hard physical labor. And, whether it's rain or sun, you are the only connect with that person in the initial rapport building stages. And even if that person does not respond to you, you will have to keep on going to that person, because it is only by repeated going, even if it is this person withdraws from you, still you keep on going till the point arrives where there is a communication, and that communication point will come, but that patience has to be there. So there are some,
So ma'am, this this manpower is trained prior to taking in, or you train them?
We train them. We train them.
Can I just add a few more things over
Yeah.
here?
I would like to ask Abir.
Yeah.
Abir, the question was that the psychiatrist run his OPD, a standalone psychiatrist. How can he help to reintegrate? I think if I'm correct, the question was that if you can throw light on that, like a standalone psychiatrist, how can he help in connecting such a person? Because we are around 9,000 to 10,000 of us, and if we all start something like this, helping at least 5 people, then we will helping to quite a good number of people.
Yeah, well, I'll answer this question along with the the last question because these two are interconnected. I think in terms of the especially with regards to the Nayadaur project, I think the central fulcrum of the care delivery is through the care workers, the healthcare, through our the social workers and also the psychologists. So as Alim was mentioning about training, yes, initial training is very important. So if you want to start, and when you start a new project, the training becomes more and more important. So once the social workers are recruited, and there would be few who would be moving along, and there will be a fresh kind of social workers being recruited in its place. So when that happens, they can see by example, the others who have worked. But what I have seen in terms of training the social workers and others is some kind of nihilism sometimes crops up because of this waiting game. You cannot treat everyone. Success stories are there, but there are failures as well. And it is not only about the black and white about success and failures. There's a huge gray zone in between, whereby you have achieved something. They would all few of them would come back to me and say that, sir, we cannot progress much further. So what is the point? I said that you are maintaining this person in the community, that you are achieving this, but they are not working. But I said that a 65-year-old man has not worked for his entire life, so you can't expect him or her to work. So even if you are providing that care, and think about if you withdraw the care, what will happen? Again, it will the person will decompensate, and the person will get into that zone where he began. In terms of a standalone psychiatrist, how it would help, you have to lead by example. So you have to put in those hours. And how is it possible? If I take my example, or example of Dr. Shrikumar Mukherjee, Dr. Prabir Pal, Dr. Ranadip Ranjan Ghoshrai, Dr. Obhiruchi Chatterjee, and all the others who have helped in the project as psychiatrists in Ishwar Sankalpa, we have to find some time out of your schedule. If I speak on my behalf, I dedicate Friday AMs or Friday PMs to Ishwar Sankalpa work, both in terms of training or in terms of field work. Prior to the beginning of COVID, we used to do field visits, be with the social workers. You have to be there. If you don't be there with them, they wouldn't get that encouragement. Unfortunately, after COVID, we are still doing kind of teleconsultations, but I hope the things will change very shortly. But since I've been involved, since I came back from UK from 2009, this is the work which you have to go into the community. In terms of my involvement with the Shortbury, I'm also involved with the psychosocial rehabilitation of the ladies who have kind of moved on from, sorry, not Shortbury, but Nanagram. So there we have sort of, it is like a UK or not a Western model clinic. So what we tend to do is that, I kind of head those multidisciplinary meetings whereby not only medications are discussed, but the holistic care of these ladies are discussed with regards to everything, their vocational work, their other kind of conflicts, that they are not being able to unite with the family, that though they don't even remember their family, or maybe some of them, their families are in Bangladesh. So there's no contact with the families. So it's a kind of multidisciplinary teamwork, members sitting together and discussing about each and individual lady and coming up with some kind of solutions if possible, or else just a continuation of care. So bottom line is, you have to be prepared to dedicate a portion of your time, a portion of your busy week towards the project, both in terms of training and field work. That's how I feel.
I think that's a very, very important practical point for all practicing psychiatrists. I think unless you make that decision of a half day in a week during working hours for this, you are not going to support any community initiative on the long term, because what you would require is that your presence, and then you are, as you rightly said, Abel, you had said that you have to be physically there with the team of people. That is very important. I think this is what we did when three of us were in the medical college. One of us had the privilege of getting out, and two others will share my work when I am in the community. That kind of a regular arrangement, if you can make, then things will move. Otherwise, we will be on that, start, stop, getting stuck. Yes.
Yeah.
To add on,
There is a
sorry,
Yeah, Minhaj bhai, there is a very important question in the chat box regarding the finances. So how do we get the finances? What are the major heads in which the finances are required? Maybe salaries or whatever the paraphernalia we are having. So, and how to wisely spend it, and what are the roadblocks there? How?
Yes.
Yeah. So we started with no money. Like I said, we started with 8 lakh rupees, I think, in 2007. So with that, we didn't even know the problem. So what happened is, with this outreach program, it's somewhat easier, because our psychiatrists hardly take any money from us. Like, they do it voluntarily mostly. And the major cost is for the salary of the staff. The medicine we try and get from OPDs of psychiatrists and hospitals also. We sometimes we take our patients to the hospitals and get medicine. Sometimes many of the psychiatrists give their samples, or whatever they get, they also used to give. So we used to collect medicine also. So medicine is a small amount of purchase we need. For food, we mobilize community for food also. So that takes a lot of effort, but we do mobilize, because we feel everyone has been part of the problem. So we need to bring everyone as part of the solution. It's not just one person. Yeah. So that way we've been able to mobilize for food. When a person is placed in a where there is no community around him. For example, if he's just sitting on a overbridge, then there is no community. Then we have to keep on providing the food. But once he starts getting better, he starts to mobilize his own food. Food is actually the least of the problem. I can tell you that. Once they start getting better, food is not a problem. Clothes is a problem, because they lose clothes all the time. I still remember, I think 4 or 5 years back, during this winter, we had given them blankets. And at that time, it was very difficult for us to gather those number of blankets. So we had given them blankets, but it was nearly New Year's time. And in the morning, we found that they had burnt all of the blankets. So I was very angry. I said, like, why did you burn? Like, it took me so many days to just get these blankets. And then one of them said that, Didi, yesterday night, it was so cold. We thought our bones will just die. If I could not stand the cold. And so, that blanket was not enough to keep me warm, also to warm myself. So 3-4 of us, we just burned so that, we could just stay a little bit of warm. We could get that warmth. My heart broke for them. Yeah. I'm sitting at home in my own, fireplace kind of a place, and they are out there on the street in the homeless people. So yeah, that is one problem. When there is a lot of variation in temperature, it becomes a problem. So sometimes medical costs are a problem because of comorbid health issues. Then they have to be hospitalized. Then they need separate, a lot of more costs. So all of those costs are going to be sort of difficult. Yes, I just saw a question if there is funding available. Azim Premji Foundation is going all out to help organizations who are helping the homeless. So if any of you here are interested in helping people who are homeless with mental health issues, please look up the website of Azim Premji Foundation. If you cannot find, then you please get in touch with me, and I will put you in touch with them. Because this is one area where we need much more work. I mean, hardly how many? All over India, you will find not more than 10, 12 organizations which are working for the homeless people with mental illness. So if we could have more of, organizations who could actually work on this issue, it would be great.
I think just to add one more line, just one more line. As Sharbhanidhi mentioned about picking up one line from the 1987 Mental Health Care Act. So the Mental Health Care Act 2017 explicitly mentions about free legal aid, sort of bypassing the judicial system, providing free care in all mental health establishments, and by definition, even a physical care home catering for mentally ill people is by definition a mental health establishment. So if this can be ensured, if this can be, if we can fight as an organization with regards to ensuring this, it would be a great help to organizations like Ishwar Sankalpa or other organizations which are working, and a bulk of the expenses are going towards catering to private care facilities, not only for physical health problems, but also for mental health problems, because as you can appreciate, not everyone in the streets can be looked into, especially when the risks are high. We have to accommodate them in some kind of custodial care for a limited period of time.
I'll just give you one example. Like, for example, we're running a shelter. We run a very modest shelter. I mean, nothing very premium about it. And if you look at our street program, per patient cost per day, it is coming to 150 rupees on the street. But when it comes to the shelter, it is nearly coming to 280 rupees per day, like everything together. So the community care program is actually a much more inclusive and resource-friendly program if we can run it. So just to share, yeah.
Okay.
What is the role of district mental health program? Are they helping you out?
There is no district mental health program in Kolkata, West Bengal. Hardly. There are only a few OPDs which run in 1 or 2 districts, but nothing to talk about, sir.
I think this is what district mental health, we have district mental health program in all districts of Kerala. So whenever an NGO approaches, an NGO who is engaged in some kind of rehabilitation, then it is mandatory for the nodal officer to cater to the needs of the NGO, especially medication part. I think this is something which the country will have to really look at, because district mental program means the country takes up the responsibility. The state would contribute by saying that we acknowledge the need, we acknowledge our responsibility as a government society. And another second thing is local self-governments, Panchayati Raj. They, in some areas, they tend to do good work in supporting mental health care, especially with NGOs. So that's one.
And there is surplus money with the district mental health program as well. So, that.
Yes. I think one health secretary called a meeting many years back and said that if there is an NGO working with the people who are homeless and mentally ill, then it becomes the responsibility of the nodal officer of DMHP to fulfill the needs of the association in terms, especially about medication.
Tufan sir has done a lot of work on this. Sir, your work on Dr. Tufan sir? Sir, can you talk about your experience in Puri? Mentally,
Puri, okay.
So,
sir, along with
I am here.
before you forget that you have done a lot of work, I remembered everything, so I told it. I think you should also talk about your experience. How you have gone about it.
I started long ago. I'll take 2 minutes time or 3 minutes time, not more than that, because it is a long story. When I became a psychiatrist in early, quite much early 80s, 81, 82, 83, then there are very few number of psychiatrists in Odisha. So I took the initiative. I was encouraged by Dr. Parthura, father of psychiatry in Odisha, and Dr. P. Saravindas, and I moved around the corners in the districts where the immediately available psychiatrists were taken. His help was such. There are also very few, like Dr. C.R. Das, Dr. S.M. Das, like that. Maybe Amit may not be knowing Dr. S.M. Das. So we held camps, and I continually held it thrice. And that gave us an inroad into their depth. And this, our friends who stayed there, they dealt with these problems. And then we found that there is a need of rehabilitation. Because they're coming back and going back and coming back with 60% recovery. And then I do believe that it is essential on the part of heavy practicing psychiatry to plan for rehabilitation whenever it is possible. As it was told by Abir, that we have to spare some time, and maybe you have to share some of your money for that also, because if you have to be hard with that. And about on this Puri, when I started going to Puri for mental health camps, which I have been organizing since early 80s, I take care of the Rotarians over there. All of Odisha has worked with Rotarians. We found that in those days, there are a lot of beggars in Puri who are not ODs. And the route was like this: people, you dump them in the train, giving them a ticket, and train stops at the dead end Puri, and they are taken out and left on the road by the police. And there was an ashram which is funded by Mother Teresa. We contacted them, and they contacted the police, and we took all these patients to that ashram. And from that day, it is maybe around 12 years, I go every month to see them at least once, and whenever they require. So this is part one. Part two is we take all care to see, at times we don't understand their language, to see that whenever we can know their address, and we have to send them back. With their help, they have a good network, and we also provide them support. And third thing about making them vocationally productive wherever it is possible, we arrange a vocation for them from where they can earn, or at least make them participate in the ashram's work and feel that they're worth it. This is all the steps we're taking in Puri, where we are trying to rehabilitate the wandering mental ill people or homeless mental ill people as they are called. But I don't call them hot. They're made homeless. They are not, all of them are not homeless. They are made homeless. And the persons responsible should be taken into task, because they cannot afford to do that. And one can do a lot of things if one does not have a rehab center. This is my stand. One can do a lot of things. When I talk to Rotarians, I usually tell them of 5 vowels. The 5 vowels I use tell them that A stands for assess the situation, and assess the situation of the patient and his community. There are a lot of promises. There are a lot of, this my personal experience, and educate the family and community. And then invest. You have to invest. You have to have money from your purse, or if not, you have to arrange. If you can arrange, it is good, and it can be arranged. When I started Special Olympics in Odisha, I was the finance committee chairman. I organized the whole fund from the streets of Cuttack city. The businessmen, small petty businessmen, they contributed. No one else, no big shot. And organize and coordinate. And after you do this for even one patient, you take one patient at a time and have a utility assessment. This is the thing I tell to all my friends who are my companions in social service: assess, educate, invest, organize, and assess utility. I tell them this is 5 vowels, I am behind you. Thank you. This is my take. Because my take is that I think I have my perspective as being a lone practitioner trying to rehabilitate. That's the minimum challenge one can take. Thank you.
Thank you, sir. Abhida, what are the frequent diagnoses, most common diagnoses in those persons?
The commonest is schizophrenia. We do get schizoaffective disorders. Very rarely bipolar disorders. I mean, bipolar disorder on its own, or maybe towards the spectrum of schizophrenia. We get a lot of depressive disorders, secondary negative symptoms, and depressive disorders with schizophrenia. So this is to do with the Nayadaur, the Shorburi, and the other wings. With the urban mental health program, we get all the things, because it's a community kind of a project, where an OPD service is run. So there also we get common mental disorders as well. Okay, and there's a very vibrant group of psychologists working along with the doctor, along with the psychiatrist. But in terms of the core homeless project, I think 90 to 95% of the diagnosis would be schizophrenia, and that too within the 20 to 30% bracket of schizophrenia who are treatment resistant. I mean, in some ways. So, we have to rely on medication as well as, of course, psychosocial rehabilitation. Just to mention the primary molecules that we use because of its ease of administration, it would be olanzapine, risperidone, and amisulpiride. We have been blessed with pharmaceutical companies giving us amisulpiride. Otherwise, it would have been very costly. And I have seen very, very good response in terms of negative symptoms with amisulpiride at a low dose. So, we use low dose, so the costs are minimized with regards to that. And supportive medications would be, trihexyphenidyl, sertraline. We use a lot of sertraline for depressive symptoms because that acts on the dopamine pathway as well. So we tend to use, very rarely we use aripiprazole, and extremely rarely we can use quetiapine. But this would be the major molecules that we tend to use. Sodium.
So out of 100 patients that you pick up, how many remain with you? What is the attrition rate?
I wouldn't be, on the top of my head, I wouldn't be able to comment on the statistics. Shobhanidhi, do you have any idea?
You have to unmute yourself.
I think 30% would be the attrition rate.
Okay.
That's a very low rate.
Can I ask a question, Dr. Abir?
Sir, please.
Yes, sir. What is the number of dementia cases you get in the group? Because I have found a good number of cases with dementia, especially elderly patients who trickle down to that group where they're picked up and we have to take care of them.
We haven't, I mean, as far as what I have seen, I have not seen, I mean, it is very difficult to diagnose dementia because, at that stage with schizophrenia, we see, mainly we see younger patients. And with regards to the elderly patients that we see, a sizable amount of that will be already have a cognitive decline in terms of schizophrenia. So there's a question of diagnostic overshadowing in terms of, whether they have dementia or not, because their functionality at the initial stages is very low. With regards to intellectual disability, we do see a lot of intellectual disability in terms of younger patients, and it becomes very difficult to tease out intellectual disability and schizophrenia till a later date when we have more information. And as Shobhanidhi was saying, that ours is more of habilitation than rehabilitation, because for the initial 2-3 years or even more than that, we do not have a clue about from where the person came, what was the background. With regards to even in my penultimate slide about Abdullah, so we never knew that he was a radiographer for a long period of time, and then we realized, and then the story goes on, but that's a different issue. But with regards to we do a habilitation for a long period of time, and then if we are fortunate enough, lucky enough to reach that stage of reintegration or knowing the family, and after we know the background, then we can gear our program towards more sort of including more things which the person would have been used to doing in the past. But sometimes we also face roadblocks in terms of, we have a few persons who have been highly employed, like they were working as drivers, and it is not possible for them to work as driver. I'm just giving an example. I remembered one person. So, but it is difficult to convince them. They would only work as, they would only hope to work to drive cars again, which sometimes becomes impossible. So these are the challenges which we face. So it would be below that person's dignity to work as a waiter in a restaurant, in a roadside restaurant. So those are the challenges which we face. In terms of dementia, very rarely do we see dementia. And with regards to the needs of the elderly, those are the people whom we prefer to house in Moruddan. The male equivalent of the the male rehabilitation or the male drop-in center which we have.
Sir,
I would just like to, Dr. Amrit, I think when you had asked about the attrition, I think I just need to put in one point. In the initial days, I think 4-5 years from when we started, the attrition would have been at around 70-80% also. Like at that point of time, we did not really understand how to, because there was no way that we could contain a person in a place. He was just free to walk away. And that is, when we started refining our own strategies and looking at our own work. Now, the reason why attrition has come down is that our registration process is also a little more stringent. So we actually take time for registration. We build report, and once the report is built, a link is established, only then we start the whole registration process and we start our services. So because of that, the attrition is also like, a lot more down, has come down. Yeah.
Do postgraduate trainees come and visit and learn from your experience? Postgraduate trainees from other institutes.
Can I answer this already, please?
Sorry.
Yes.
Well, it's a constant process from our side to involve the postgraduate trainees. We have met with limited success. I mean, we as a team have approached the various medical colleges to explain that how important the community model is, and it is shouldn't only be confined to the synopsis of psychiatry and the comprehensive textbook of psychiatry. You have to learn the nuances of community work, and what better way to do it than this kind of a project. And since I've had my UK experience, so I've seen how community model works over there, and I wouldn't hesitate to say that in many ways a project like Ishwar Sankalpa or various other projects which are working all over India follows a community model in a much better framework than in the UK models which I have worked in.
I agree with you fully.
Sir, do you use depot injections?
Not yet. We have deliberated over it. In terms of clozapine use, also we feel a lot of problem. Clozapine is used in the shelter homes, especially the ladies' shelter home. There are a few service users who are on clozapine, but not in the Nayador project, not in the community. It's too risky because there are sort of, and even with terms of using haloperidol, we have to be extremely careful, because there have been instances where there have been severe EPSs and the community all over us, in terms of when everything works fine, it's fine. When something goes topsy-turvy, then the whole community would be on you with regards to what is happening, like why is this thing happening? Why aren't you taking the person to the hospital? So that is, when I mentioned about olanzapine, amisulpiride and risperidone, amisulpiride at low dose specifically, because we know that amisulpiride at high doses can cause EPS. And with risperidone, it's always with the cover of trihexyphenidyl that we tend to use. With the olanzapine, we use it without trihexyphenidyl. So yes, I mean, we do use, but depot, we have deliberated over depot for a long period of time. The expenses are high. To use the first generations is very risky. With regards to the second generation, the cost escalates. So, all these things have been taken into consideration, but still we haven't explored that area.
So I'll read one line from the comment section and then hand over to the chairpersons for the final comment. To Dr. Abir and Sarvanidhi, your work has been beyond our imagination. Hats off to your efforts. So this is one of the cutest comment in the chat box. Over to chairpersons for their final comments, and then Amrit.
I think it had been a very, very useful experience. There are two things, takeaway points, messages. One is that we as a group of professionals, we must follow activities like this, because we have a responsibility to ensure that people with schizophrenia is provided with a rightful space in this world where we all share this world. So we have to make sure that they get the right space. We need not promise them the whole world, as some ad said. Second thing is, it is very important that postgraduate trainees get opportunity to see what is happening in primary care in terms of district mental health program. We had introduced this towards the later part of my career. And the feedback was excellent. It is one thing to sit in the tertiary care outpatient department and write prescriptions. It is a totally different thing when you sit in a primary care setting or a community setting and handle people. It is more than pharmacology. It's all about realities of life. Thank you very much. I am delighted to be here today, and it was a great sharing of experiences. Thank you all. Over to my co-chairperson. Thank you, Abir and Sharbani, very much.
Thank you. Thank you.
I would like to say thanks to Alim for and Topan Pati sir, Amrit for inviting me as co-chairperson of with Dr. Shaji. I would like to congratulate Dr. Abir and Sarbani Di for their wonderful work. I would also appeal to all psychiatrists listening today that they should all try to reach out to people, go out of their OPDs and their tertiary care departments and go out and see if there are any social workers working for these people. Because I believe there are lots of people, temples, mosques, dargahs, places like this working for these people, mentally ill people, providing them with food and shelter. What we as psychiatrists can do is go to these places and at least provide some basic medicines, some through government, the program, the district mental health program through that, or from our own pocket, some simple medicines like trifluperazine, which are very cheap. Go to those centers and provide them medicines. We at Hyderabad, we have a dargah wherein one psychiatry department from a medical college goes over there every Friday and gives them medicines. So this is how we can help wandering and mentally ill people. And as everybody was, Shaji sir was saying that postgraduates should also be exposed to these people rather than teaching them just hardcore treating hardcore psychotic patient or depressive patient. We teach them how to take care, go to the community and take care of people wandering mentally ill and other destitutes. Thank you. Over to Amrit.
Yeah, thank you. So it was wonderful listening to Abir sir, always a brilliant speaker, and Sarbani madam, congratulations for thinking way beyond what we would have thought in a normal course of time. No, I have an interesting story to add. Few days back, I was sitting in my clinic. I got a call from a press reporter that there is a wandering person nearby. So he had lost his parents. This chronic schizophrenic, he was a treatment-resistant schizophrenic. He had lost his parents, and his brother was hitting him, and he had driven him out of the house. Finally, his friends found him near my clinic actually, and they called up some press reporter who called me up because I'm little active on the media circle. So when I went, I directly went from my clinic, had an injection, and the best part or the worst part was everything was recorded. I went, I examined the patient, I gave an injection to the patients. I took him in my car and brought him to my hospital. I gave a commitment there that our hospital people will treat him. We kept him for 45 days. He ran up a bill of around 50,000-60,000 because we are giving food to 2 people. He was treatment resistant. So like sir was telling, I think 30% of these patients would require clozapine. And finally, we had to give him clozapine. It took a lot of time because the duration of untreated psychosis was too long. And finally, we could get him back to society, and it was a very good example for everybody around. It's at maybe it is one patient once in a while we do it, but the press sometimes carry a positive story about the doctors also, and it did a lot of good things. A lot of people started asking that if you have such patients, we are ready to finance them, we are ready to pay money, talk about treatment. A lot of my patients came to me and told me that, sir, keep this money. If there is any patient, you please tell us 6 months, 1 year, So what we managed to do is we managed to form a small circle, and we are able to support 20-30 patients. It is very small, but that's something. There is a movement in the positive direction, and it goes a long way in helping people. So I think the whole model is superb. We also have we have a center where wandering lunatic females can be kept. So whenever we see a female who is on the streets, what Abir sir was talking about, sexual abuse is a very, very common thing. People abuse, very active people. So these people are vulnerable, and that is where we can immediately, we have a place where we can keep them and we can rehabilitate them, not just habilitate them. So wonderful listening to Madam and Sir, Saji Sir, and my close friend Minaj. You have been very, very good. Minaj has been very, very articulate, done a lot of research. So thank you so much. We also heard Dr. Tofan sir, he has been doing a lot of work in Puri, because these patients end up like what Minaj was talking about, temples, mosques, maybe churches, bus stands, and stations. They're the places where they get food. People give food, people throw food. So these are areas where they can sleep, where they can, so somewhere they also search for security, where they can get a little bit of food, but they're a little safer than in the streets. So I think that these are the areas where we can focus if you really want to, get a better, less attrition rate, and then once in 6 months, I think with treatment, they finally talk about their homes. If you're intelligent enough to ask them, because I have got calls from Kerala, Gujarat, Maharashtra, where my friends in centers have called me up about Odia patients, and we have managed to bring them back. And we have managed to send back also a lot of people. We see wandering lunatics, and we have to send them on flights. They don't have an Aadhaar card. That is where the problem is. They don't have identity cards. But yes, there are people who help. Even in airports, there are CISF people. If you talk to them, you personally go and tell that this is a wandering lunatic. We found it and we are trying to send him back to maybe Kerala or Gujarat. There are people who are helping. So lot of the whole society, there are a lot of people who help, including the police and all. And if you are cooperative and if you are open, I think people are there to lend a hand. That's what I will always tell. So once we do things, people around us also understand that yes, they can also do such things. And I think it was wonderful. There are a lot of rehabilitation webinars going on today, but then we managed to pull in more than 100 people. So it was good. Thank you so much, Alim, for moderating. I'm not well. So finally, I came after 3 weeks to this musings. So thank you everybody for tuning in. I think we'll again talk to you, madam and Abid sir, how to go about maybe in the community, how we can help. Maybe the IPS people can understand and maybe we can go forward from this. Thank you so much. Good night. Hope to see you next week again. Thank you.
Thank you.
Okay, bye-bye.